This podcast was created with the help of artificial intelligence. All content has been reviewed by a medical content expert to ensure accuracy before publication.
Welcome to the Deep Dive. Today we're navigating the intricate and sometimes quite unpredictable landscape of pediatric immune thrombocytopenia, or ITP. This is an autoimmune disorder that significantly impacts a child's platelet counts and, really critically, their bleeding risk.
It really is. It's a condition where, the stakes are high and making the right clinical decisions can profoundly shape a young patient's quality of life and their long-term well-being.
Absolutely. So our mission in this deep dive is to equip you, as a clinician, with the most current strategies for stratifying these pediatric ITP patients.
Yeah.
We're going to delve into the nuances of selecting appropriate first and second-line therapies, discuss effective monitoring, managing those chronic complications, and also take a look at the really exciting realm of new and investigational treatments coming down the pipeline.
Exactly. Our overarching goal here is to help refine your clinical practice, making sure we achieve the best possible outcomes for children living with ITP.
Okay, so let's unpack this from the beginning. At its core, what exactly defines pediatric ITP for us?
Well, pediatric ITP is an acquired autoimmune disorder. In essence, the body's immune system mistakenly produces antibodies that attack and destroy its own platelets.
Right.
And that leads to low platelet counts, what we call thrombocytopenia. What's particularly interesting and maybe often overlooked is that these antibodies don't just destroy existing platelets, they can also target the megakaryocytes.
Ah, the precursors.
Exactly, the precursor cells in the bone marrow that make platelets, so it can diminish new platelet production too. And this whole autoimmune response is frequently triggered, we think, by an overreaction of the immune system, often after a viral infection, like a common cold or the flu.
So an immune system gone a bit awry, often after just a routine illness. How do we classify the disease course then? Based on duration?
Yeah, we categorize it based on how long it's been going on. Newly diagnosed ITP is the first 0 to 3 months. If symptoms or low counts persist beyond 3 months, up to 12 months, we call it persistent ITP.
Got it.
And if it continues for more than 12 months, then it's classified as chronic ITP.
And what does this look like clinically? When a child presents, what are the typical signs we should be looking for beyond just that lab result?
Patients might present with easy bruising purpura or those small pinpoint red spots called petechiae, often on the lower legs. Beyond skin signs, you might see bleeding from the gums or nosebleeds, or even blood in urine or stools in more severe cases. And it's important to remember it can also really impact their quality of life, fatigue, frustration for the child and the family.
Yeah, it's clearly more than just a number on a lab report. But when is treatment actually indicated? Because you said it's not always a given, right?
That's a critical point. Treatment isn't always necessary, especially for asymptomatic patients, even with quite low platelet counts.
Okay.
However, intervention becomes crucial for patients who are having significant bleeding, or maybe they have other hemostatic defects, or if they have planned surgery or high risk of trauma. We also consider significant comorbidities that increase bleeding risk, or certain lifestyle considerations, where bleeding would be particularly hazardous.
Right. So when we do decide to treat, what are the overarching goals? What are we really aiming for?
Our primary goal, above all else, is preventing serious, life-threatening bleeding. That's number one.
Makes sense.
Secondary goals include promptly increasing the platelet count, typically aiming for at least 30 to 50 by 109 L to address any current bleeding symptoms and prevent future ones. We also want to improve their health-related quality of life, minimize treatment toxicity, and ideally achieve a treatment-free response or remission.
And you mentioned something important earlier.
Yes, it's vital to remember that in pediatric patients, the goal is really symptom control and safety, not necessarily normalizing platelet counts to adult levels. That's a key difference.
That distinction is incredibly important.
Yeah.
Okay, to ground these guidelines in practice, let's consider a patient. Let's call her Cassandra. She's 9, newly diagnosed with ITP, presents with mild bruising and petechia, just skin stuff.
Okay.
No mucosal bleeding. Her platelet count is 22 AT10L. Treatment naive. This is our starting point.
Like a very typical presentation.
So, with Cassandra in mind, what are the key factors we use to stratify these pediatric ITP patients, especially when we're thinking about initial therapy?
Risk stratification in pediatric ITP really hinges on 3 core factors. First, the bleeding risk. That fundamentally dictates the urgency and intensity of our initial therapy.
Right.
Second, the likelihood of progressing to chronic disease, which helps us plan long-term. And third, treatment tolerance, that balancing act between efficacy and side effects.
And biomarkers. Anything there yet?
Well, research is ongoing into things like antiplatelet antibodies or genetic markers, but honestly, they're not yet routinely used for direct clinical prediction in most places.
Oh, okay. So how do we systematically evaluate that bleeding risk? I know there's a scoring system.
Yes, we use a standardized bleeding score. It ranges from grade 0, no new hemorrhage, up to grade 5, which is life-threatening or fatal bleeding.
You can give some examples.
Sure. Grade 1 is minor skin bleeding. Grade 2 is mild, maybe numerous petechia. Grade 3 could be low risk, like blood crusting in the nose, or higher risk, like a nosebleed lasting over 5 minutes. Grade 4 is severe mucosal bleeding or suspected internal hemorrhage.
And the key insight here for kids.
What's often crucial is that many children have only mild bleeding symptoms, and spontaneous resolution is quite common in pediatric ITP.
Right.
So, for children with no or only mild bleeding, meaning just skin manifestations, outpatient management and observation is often appropriate, regardless of their platelet count. That's a big shift from automatically treating the number.
That's really critical to underscore outpatient management for mild cases. Given that, what are our main first-line treatment options then?
The initial options include, as we said, observation for those with no or minor bleeding. Then there are corticosteroids like dexamethasone or prednisolone.
This standard steroid.
Exactly. Then intravenous immunoglobulin or IVIG and anti-D immunoglobulin, where it's available, less common now in many places.
And for those very mild cases, what's the general recommendation? Observation first.
Yes. For children with newly diagnosed ITP and no or minor bleeding, the expert panel actually conditionally recommends observation over starting corticosteroids, IVIG, or anti-D.
Why is that?
It really highlights that high rate of spontaneous remission and the desire to avoid unnecessary treatment side effects in this group.
Okay, let's dig into corticosteroids, a common first step if observation isn't chosen. How do they work, and what's that tension between benefits and risks, especially for kids?
Corticosteroids, they work in a few ways. They can promote platelet generation, suppress autoantibody formation, decrease platelet clearance by the spleen, and maybe stabilize blood vessel walls.
So multiple effects.
Yes. Their main benefit is often a rapid increase in platelet count. Plus, they're familiar, low cost, can often be given at home.
But the downsides?
The core tension is their toxicity. Acutely, you can see fatigue, insomnia, irritability, hyperactivity. But for children, the big worry is long-term toxicities. Weight gain, cataracts, diabetes risk, and critically, osteopenia and impaired growth.
So definitely not a long-term solution.
Absolutely not. They're a short-term sprint, not a marathon. That's crucial in pediatric ITP.
That's a great way to put it. How do we monitor and manage patients on these short courses?
We typically check a platelet response within 3 to 7 days. We also monitor blood pressure, glucose, mood, behavior. Parents often notice changes quickly. Younger kids can be quite sensitive.
And management strategy.
Limit use to very short courses, ideally 7 days or less. If there's no response or if they relapse quickly, we need to look at alternatives pretty fast.
Okay, so if steroids aren't the answer or aren't tolerated, what's next? IVIG often comes up. How does that fit in?
IVIG works differently. It essentially floods the system with immunoglobulin G, which blocks the XCO receptors on macrophages, particularly in the spleen.
So it stops the macrophages from eating the platelets.
Exactly. It prevents them from binding to and destroying the antibody-coated platelets. Its key benefit is a very rapid increase in platelet count, which makes it invaluable for acute, significant bleeding.
But downsides?
Well, the effect is often short-lived, maybe waning within weeks. Risks include infusion reactions, headaches, and aseptic meningitis that's more common with IV. Hemolysis can happen, more so with anti-D, and it usually requires hospital administration.
Any specific pediatric concerns with IVIG?
Yes, children seem to be at a slightly increased risk for infusion reactions and aseptic meningitis, so you need really vigilant monitoring for subtle behavioral or physical changes during and after infusion.
And how do we monitor these patients?
Check platelet response within 24 to 48 hours. Watch closely for bleeding symptoms and adverse reactions, headache, stiff neck, hemolysis signs. Rarely monitor renal function.
Management-wise?
It's typically reserved for urgent platelet elevation needs. If the response is transient but elevation is still critical, maybe repeat dosing. But if the response is inadequate or too temporary, you quickly move on to evaluate other treatments.
Okay, let's circle back to Cassandra. Remember, 9 years old, mild presentation initially.
Right.
But a few months later, she's back. Her mom reports frequent nosebleeds.
Oh.
On exam, she has blood crusting in her nose, lots of petechia over 150, and 2 large bruises. That puts her at grade 3 bleeding.
Okay, definite worsening.
Her platelet count is 17 times 10 to the 9th per liter. She had a short course of corticosteroids, which gave some relief, but her parents noted significant behavioral changes, poor sleep.
Very common side effects.
And a week later, her symptoms only showed minor improvement. So this sets up that classic dilemma. She needs something more, but the steroids are tough. How do we approach second-line therapy here, considering efficacy, side effects, family preference?
This is exactly where the 2019 ASH Pediatric ITP guidelines are so helpful. For children unresponsive to first line, the panel offers conditional recommendations.
What do they suggest?
They suggest using thrombopoietin receptor agonists, or TPO-RAs, rather than rituximab.
Okay.
They also lean towards TPO-RAs over splenectomy. And if a TPO-RA isn't suitable for some reason, rituximab is generally preferred over splenectomy.
What's the thinking behind that order?
The rationale is generally that TPO-RAs are seen as having lower risks and potentially high benefits compared to the other two, and rituximab is usually considered less risky than splenectomy.
And a key point about splenectomy timing.
Yes. A crucial good practice statement is to delay splenectomy for as long as possible, at least 1 year from diagnosis, because of that chance of spontaneous remission, especially in the first year. Don't rush into surgery.
That emphasis on delaying splenectomy is really significant. What other guiding principles are there for choosing second-line treatment?
The choice must always be highly individualized. You have to consider the duration of ITP, how often bleeding requires hospitalization or rescue meds, any comorbidities, adherence issues, support systems, and very importantly, the patient's and family's values and preferences.
And practical things, too.
Absolutely. Cost, availability of the treatment, patient education, and shared decision-making are really not optional here. They're central to finding the best path for that specific child and family.
Okay, let's dive deeper into TPO receptor agonists, since they're often preferred second line. How do they work, and which ones do we have for kids?
TPO-RAs mimic thrombopoietin, the body's natural platelet growth factor. They bind to TPO receptors on megakaryocytes in the bone marrow, basically telling them to make more platelets.
Stimulating production, not just preventing destruction.
Exactly. In pediatric patients, avatrombopag, eltrombopag, and romiplostim are the currently indicated options.
What are the main benefits and potential risks clinicians need to keep in mind?
The key benefits are achieving a durable platelet response, reducing bleeding events significantly, and importantly, improving quality of life. They're suitable for long-term management, often getting kids off steroids.
And the risks.
With eltrombopag, we monitor liver function tests as enzymes can get elevated. There are also some dietary interactions calcium can interfere with absorption. Both have a low theoretical risk of bone marrow reticulin changes, though it seems rare clinically. Rebound thrombocytopenia can happen if stopped abruptly, so regular monitoring is essential.
How do we monitor and manage patients on agonists, especially initially?
Monitor platelet counts weekly when starting, then usually monthly once stable. Liver function tests for eltrombopag. Keep an eye out for thrombosis risk, though generally low. For eltrombopag, monitor for cataract development, though again seems rare. Adherence is key.
And the goal for dosing?
Adjust the dose to maintain a safe platelet count, usually aiming for above 50 times 10 to the 9th per liter, and then taper to the lowest effective dose to minimize any potential side effects. If response is lost, you need to reevaluate.
Now this brings us to some really potentially practice-changing data. The PINE study looked at using TPO-RAs up front. What were the key findings?
The PINE study, Pediatric ITP, newly diagnosed patients, eltrombopag versus standard therapy, was a really important randomized trial. It looked at newly diagnosed kids who needed treatment.
And the result?
The headline finding was significant efficacy. 65% of the kids on eltrombopag met the primary endpoint sustained platelet counts over 50, compared to only 33% in the standard of care arm.
Wow, that's a big difference.
Huge. It was so compelling that the study was actually stopped early for efficacy. This suggests TPO-RAs might become a new starting option for some pediatric ITP patients, moving them much earlier into the treatment pathway, potentially avoiding steroids altogether in some cases.
That really could shift the paradigm. Okay, let's switch gears to rituximab. Different mechanism, right? Pros and cons.
Yes. Rituximab is an anti-CD20 antibody. It targets the CD20 antigen on mature B cells, the cells that eventually produce autoantibodies. It essentially depletes these B cells.
Reducing the antibody source.
Precisely. The main benefit is the potential for long-term remission in some patients, but the effects are often transient. Over 60% of responders might relapse within 5 years.
And the risks.
Key risks include decreased vaccine responses, very important in kids' potential infusion reactions. It's not suitable for acute bleeding because it takes time to work. And there's a risk of persistent hypogammaglobulinemia, meaning low antibody levels long-term, increasing infection risk.
How are these patients monitored and managed?
Monitor closely for infusion reactions. Check B-cell levels to see the drug's effect. Watch for infections, especially during B-cell depletion. Check immunoglobulin levels periodically. Response time varies, weeks to months usually. Additional doses might be needed.
Okay. And finally, the major intervention, splenectomy. Mechanism, benefits, and the considerable risks for kids.
Splenectomy removes the main place where antibody-coated platelets are destroyed, and also a site of antibody production. The main potential benefit is long-term remission without needing ongoing medication, and it gets kids off steroids, which is a big plus.
But the risks?
The risks are substantial, especially for children. Immediate surgical risks, sure, but more importantly, a lifelong increased risk of severe, overwhelming bacterial infections, OPSI, overwhelming post-splenectomy infection. Also, a long-term increased risk of thrombosis and decreased response to vaccines.
Plus practical implications.
Lifelong monitoring, potential limits on activities like contact sports, psychological impact. It's really considered a last resort, especially now with better medical options like TPORAs.
Given those risks, what are the crucial monitoring and management points post-splenectomy?
Patient and family education on recognizing fever immediately is paramount. Lifelong vigilance is needed. Monitor platelet counts closely post-op. Ensure appropriate vaccinations, especially for encapsulated bacteria, are given well before surgery, at least 2 weeks prior.
Antibiotics.
Yes. Antibiotic prophylaxis is recommended for kids under 5 and for at least 2 years for everyone post-splenectomy, sometimes longer depending on individual risk. And again, reinforced delaying splenectomy for at least that first year. Okay, let's check back with Cassandra. A year later, she's doing very well on her TPO-RA.
Good news.
Yeah. Her family is now asking about long-term treatment, what the future holds, which leads us perfectly into the emerging and investigational therapies.
And it feels like there's quite a bit happening in this space, right, beyond our current options.
Absolutely. The pipeline is exciting. We're seeing newer TPRs like avatrombopag and hetrombopag being studied in kids.
4 options within that class.
So, avatrombopag was just recently approved in pediatric patients aged 1 and up with persistent or chronic ITP, based on promising safety and efficacy data in a phase 3 trial. The study showed that 27.8% of patients treated with avatrombopag achieved the primary endpoint of durable platelet response versus 0% of placebo patients in the absence of rescue medication. Overall, the avatrombopag was generally well tolerated with an acceptable safety profile. This opens up more choices for patients who maybe need different dosing or agents with different side effect profile. Ibrutinib, a BTK inhibitor, Bruton's tyrosine kinase inhibitor.
How's that work?
It's quite broad. It blocks the B-cell receptor pathway, inhibiting B-cell activation and antibody production. It also seems to block Fc gamma receptor signaling involved in platelet destruction by macrophages. So it hits multiple points in the ITP process.
The data?
A phase 3 trial in adults and adolescents showed durable responses, better overall platelet response than placebo, and less need for rescue therapy. Crucially for patients, it also showed improvements in fatigue and bleeding scores.
Addressing fatigue is a big deal.
Huge quality of life factor. So this broader mechanism might offer benefits beyond just platelet counts.
Any other novel antibody approaches being explored?
Yes. We're seeing development of antibodies targeting different immune cells. Daratumumab, for example, is an anti-CD38 antibody. CD38 is high on plasma cells, the main antibody factories.
So targeting the source again.
Right, but maybe more specifically the long-lived plasma cells. It's in a phase 2 study for pediatric ITP. Early literature reviews suggest it can induce complete responses in some refractory patients, though pediatric data is still limited.
Interesting.
Yeah.
And another one?
Obinutuzumab. This is another anti-CD20 antibody, like rituximab, but it's engineered for enhanced B-cell killing. It's also in a phase 2 study for adolescents with ITP. Adult data in refractory ITP looked promising, showing sustained responses, so refining the anti-B-cell approach.
This evolving landscape is definitely promising. But even with these new tools coming, managing ITP still has significant challenges, doesn't it?
Oh, absolutely. There are quite a few hurdles. We still grapple with the fact that existing therapies have limited efficacy for some and variable toxicity. Finding the right fit for each child can still be a journey.
And comparing treatments.
That's tough too. We lack strong head-to-head comparative studies between many treatments, which makes evidence-based choices harder. Long-term remission rates outside of splenectomy are generally not as high as we'd like.
Other challenges.
We still lack really good standardized tools for measuring quality of life, specifically in pediatric ITP.
Right.
And a big one, we don't have clear predictive biomarkers yet to say this child will respond best to this drug. And sometimes there's a disconnect between the physician's perspective and the patient and family's experience and needs.
So given all that complexity, the options, the challenges, what factors ultimately influence your treatment choices in practice?
It's truly multifactorial. You've got disease factors, bleeding risk, platelet count, phase of disease, symptoms,
Right.
then treatment factors, likely response, tolerance, the schedule injections versus pills, daily versus weekly. Patient factors are huge. Their characteristics, other meds, comorbidities, adherence potential, and crucially, patient and family preference and lifestyle sports activities.
And external things too.
Yes, financial constraints, insurance approval, guidelines, local availability, and even physician experience and comfort level with different agents. It all plays a part.
That comprehensive view leads directly to shared decision-making. It sounds absolutely vital here. Why is it so critical in ITP?
It's critical because ITP treatment decisions are complex. You have multiple options, especially second line, each with different pros and cons, different administration routes, different monitoring needs, and patients respond differently.
So the conversation is key.
Exactly. Engaging families in shared decision-making significantly improves their understanding of the condition and the options. It boosts their satisfaction with care, and really importantly, it enhances adherence to whatever plan is chosen together. When families feel heard and are part of the decision, they're more invested.
That makes complete sense. Are there resources available to help clinicians and families navigate these conversations?
Yes, definitely. Patient support groups like the Platelet Disorder Support Association, PDSA in the US, or the UK ITP support group offer excellent materials, infographics, summaries designed for both patients and clinicians. They can be really helpful tools to facilitate these important discussions.
Great. As we wrap up this deep dive, let's summarize the key takeaways for our listeners managing pediatric ITP.
Okay, first and foremost, personalized treatment is essential. Base it on bleeding risk, likelihood of chronicity, and always patient and family preferences and values.
And we learned TPO receptor agonists are really changing the game.
They really are. TPORAs offer durable, steroid-sparing options. And with studies like PINES, we're seeing them used increasingly early, which is a major advance for kids.
Monitoring clearly is much more than just the platelet count.
That's right. Monitoring has to include not just platelets, but also bleeding assessment, tracking side effects, and really paying attention to health-related quality of life.
And finally, that ongoing dialogue is crucial.
Absolutely. Shared decision-making and constantly reassessing the risk-benefit balance are essential, especially when considering long-term therapy or a major step like splenectomy.
So here's a final thought to leave with you. As this landscape of ITP therapies continues to evolve so rapidly, how might the integration of new predictive biomarkers when they arrive further refine our ability to offer truly personalized, proactive care, ultimately improving outcomes and quality of life for our young patients? We leave you with that thought.